Thank you for your instruction. I'm Dr. Ying Wu. I'm a neurosurgeon and the director of pain medicine at the China Medical University Hsinchu Hospital in Taiwan. Today my topic is image-guided core radio frequency rhinotomy for sacroiliac joint pain. This is a typical case of SI joint pain. This female suffering from 1 year severe low back pain, and he received long segment and multi-level lumbar sacral fusion 3 years ago. The MRI revealed that was adequate lumbar sacral decompression. However, the patient still feels severe pain, and she can't sit or stand for more than 30 minutes. So under the diagnosis of SI joint pain, I performed the core radio frequency and the pain much relief. Low back pain is almost the most complaint in neurosurgeon, orthopedic, and the rehabilitation outpatient clinic. But however, not all the patient, all the low back patient comes from the spine. About 25% of low back pain comes from the hip or SI joint pain. Especially the SI joint pain is usually under diagnosis. The SI joint is the largest, one of the largest joints in human body. It's complex, and besides the joint capsule itself, but including surrounding ligament and muscles. The SI joint carry the upper body weight and transfer the load to bilateral leg. Its range of motion is limited. It's just about 1 to 2 degrees, and it transfer the translation is at least 2 millimeters. So if trauma or repetitive inflammation will lead to pain in this region. It has been long time. It's a lack of consistency of SI joint dysfunction, because its mobility, its role in pregnancy, and anatomy variation remains controversial. Besides, since the disc herniation discovered in 1934. Many physicians tend to believe that the low back pain always comes from the spine. So the SI joint pain is largely ignored in low back pain research. So without definite diagnosis, the patient may receive inappropriate treatment or surgery. It fails to relieve pain, but also develop the new problem. We often talk about the SI joint pain, but pain is just a symptom. The underlying cause is the joint dysfunction. The mechanism of SI joint comes from the intra or articular etiology. The most cause of SI joint pain is trauma and the post-lumbar sacral fusion. About 70% of SI joint dysfunction comes from the extra-articular. The nerve innervation of extra-articular is from the L5 to H3 lateral branch. We call the sacral network. By blocking the lateral branch, about 70% success in relief the SI joint pain. About 30% come from the intra-articular. The typical symptoms deep and the anterior growing pain. The innervation from to the intra-articular is from the L4 and the L5 ventral rami. The SI joint pain pattern is usually referring pattern is usually overlap with the disc herniation and the facet pain. So it is important to differential diagnosis of the SI joint pain and disc herniation and the facet pain. The SI joint dysfunction remains clinical and the radiographic challenge. The symptoms including the low back pain below L5 level and the radiation to the buttock and the posterior side and the low leg with poor sitting tolerance. There are 6 provocative tests for SI joint pain. If there was more than 3 tests was positive, then we will highly suspect the SI joint pain. However, no image study has been found to accurate direct diagnosis in SI joint pain. But it is important the image can identify the fracture, infection, and the tumor for SI joint. More than 50% of asymptomatic adults shows SI joint degeneration on image. There was many image experts today here, but when it comes to SI joint, the image doesn't matter. According to the IASP, the International Association for the Study of Pain Criteria for SI joint, in 2009, the first is the symptom. The patient is suffering from low back pain and below L5 level. The second is physical examination, and at least 3 out of 6 provocations positive. And the third is we use the diagnostic joint injection with anesthetic. A review paper published in the Journal of Pain, it suggests the ISP criteria for SI joint should include the pre-articular injection. So this is the internal conference of SI joint surgery and the research in Japan. The diagnostic algorithm suggests that we should start with pre-articular injection first. If it fails to relieve the pain, then we will proceed to intra-articular injection to confirm the SI joint pain. There are 3 methods of diagnostic SI joint injection. The first is a pre-articular injection, the second is lateral branch block, and the third is intra-articular injection. Almost diagnostic SI injection needs the image guided, including the fluoroscopy, CT, or ultrasound. We usually inject with the local anesthesia with or without steroid. The first, the pre-articular SI injection is for the dorsal extra-articular complex, including the surrounding ligament and muscle. So the pre-articular SI injection is under the fluoroscopy or the ultrasound. This is a technique I mostly use in my outpatient clinical because it's safe and fast and effective. This female suffering from left buttock pain for 1 year. He had a history of L4 and L5 fusion. So under impression of the SI joint, I performed the ultrasound-guided pre-articular injection, and he got much pain relief immediately. So the SI joint pain is diagnosed. The second is lateral branch block. It's for the dorsal extra-articular complex and the dorsal SI joint capsule. This procedure is usually performed under the fluoroscope. The needle is positioned lateral from the midline at least 30 millimeters to avoid the puncture into the sacral foramen. And our target is superior lateral and inferior lateral quadrant of each sacral foramen. If we usually under the suspect of SI joint pain, I usually perform the pre-articular injection and then lateral branch injection. But if the pain persists, then I will proceed to intra-articular injection for the anterior SI joint pain source. The intra-articular SI joint injection is for ventral SI joint capsule pain. So I usually perform this procedure under the fluoroscope. The CM will rotation contralateral and oblique to 5 to 20 degrees. Then rotate the caudally about 30 degrees. When we see the SI joint capsule clearly and the needle was advanced into the joint, and I inject the contrast to make sure the needle position. This is another case of a severe back pain. He has a history of L3 and L4 fusion. Although the image, the MRI revealed there was L2 and L3 adjacent segment degeneration with spinal canal stenosis, but the pain region is over the right side SI region. So under impression of SI joint pain, I performed the pre-articular injection in my outpatient clinic, but the pain didn't relieve. So I proceed to the intra-articular SI joint injection in OR, and the pain is much relief. So the patient is the intra-articular SI joint pain. After the diagnosis, definitely the diagnosis of SI joint pain, we usually start with the conservative treatment. If it fails, then the next step is SI joint neurotomy. There was 2 review articles talk about if conservative treatment fails to relieve the SI joint pain, then intra-articular corticosteroid injection and the radio frequency, especially the cool radio frequency treatment, can be considered. There are three types of SI joint neurotomy. I usually use the cool radio frequency because it creates a deep and the large region inside and avoid the tissue charring. Compared with protruding or monopolar probe of radio frequency, the cool radio frequency creates the largest and the near spherical region side. The SI joint cool radio frequency is performed under the fluoroscope guidance. There were 9 points. Our target is L5 dorsal ramus and S1 to S3 lateral branch. Each point we operate at about 60 degrees Celsius for 180 seconds. And the motor stimulation should be tested to prevent the injury to the sacral nerve. This is the kit of SI joint, the cool radio frequency, including its needle and its cooling system. This is a case of trauma. He falling down on buttock last year and suffering from left buttock pain for 1 year. And also I performed a pre-articular injection in my outpatient clinic, and the pain relief for about 1 week. And finally, I performed the cool radio frequency for him, for her, and the pain was much relief and back to daily activity. This is systemic review of the SI cool radio frequency for SI joint. It's safe and effective. If the SI joint recurred, the second procedure can provide longer duration than the first one. This is my preliminary data on cool radio frequency for SI joint in my hospital. After diagnostic injection positive, I select about 100 patients with female dominant. The most cause is post-lumbar sacral fusion and trauma. Mean follow-up more than 2 years, and the pain score improving by 5 points. The effective rate is about 85%. There were 6 patients recur in around about 7 months, but there was no neurogenic deficit. Take-home message. It's important to definitely diagnose the SI joint pain because there are many causes of low back pain. But we can use the diagnostic block for the SI joint first, and after the diagnosis is confirmed, the cool radio frequency is effective and safe. Even older patients will receive, have the positive of diagnostic block, but theoretically, the cool radio frequency effect rate is 100%. But some patients combine with intra or extra-articular pain, so the effective rate is about 85%. If the pain proceeds for a refractory SI joint pain, the SI joint infusion should be considered. Thanks.